Welcome to Module 2, Motivation and Health Behavior Change, as part of K&H 329. This is a very extensive topic, and we're going to not probably give it to just due, but we are going to get into a variety of issues. And you've got three main assignments, learning activities in this module. The change game, which is a very kind of brief, fun, hopefully fun, kind of metaphorical way in which you might be able to understand behavior change a little better. We also have technology and health behavior change, where you examine what you believe about the role of technology in health behavior change. And then you have kind of a major learning experience, the health behavior personal experience paper, which is 15% of your grade. And you can choose any of the behaviors that are on this list here. There may be others that you might want to explore that might be a health behavior. These are on the list because they're all related in some way, shape, or form to morbidity and mortality. Many studies. Reading number 4 highlights some of these studies. The Alameda County study, which has been going on for a long time, they've looked at these kinds of behaviors and their links to morbidity and mortality. Now, what is morbidity and mortality? Well, morbidity is the number of cases of disease at any one time. Mortality is the numbers of deaths due to particular causes. If you're really interested in this kind of work, there's the profession or discipline of epidemiology. And that's really what they do. Health epidemiology can get into the ideas of how lifestyle might be related to both morbidity and mortality. Also, reading 1 highlights this a little bit more if you are interested in that, but we don't have time to get into a lot of the epidemiological aspects. We're just basically using this as a framework. Yes, these behaviors right here, quality of sleep all the way down to safe driving or unsafe driving, are linked to morbidity and mortality, and sets kind of the framework for Module 2. Now, we all know that these behaviors are good for us, right, in some way, shape, or form, but the data is pretty clear that there's a low percentage of the population that actually participates in these health behaviors. Again, I've been following this data for a long time, but one significant study showed basically 3% of all Americans basically do kind of the package of behaviors that we would like people to do, and that is keep weight off, exercise regularly, eat healthy, and avoid smoking. 3% of all Americans do that packet of lifestyle behaviors over the course of any one time. So we've got a long way to go. A lot of challenges of health behavior change, and again, the change game is just kind of one, hopefully somewhat a creative way to have you learn a little bit more about that, and you'll be doing that as well. So the logic is pretty clear if you've been in this field a while, which many of you are in classes and you're getting this drummed into your brains, right? That this is pretty much the logic of primary prevention. There's 3 different aspects of prevention, right? Primary, secondary, tertiary. We're not going to get into all these different levels, but primary is basically you try to change health behaviors before these risk factors develop, like high cholesterol or hypertension, right? Change before it happens. You reduce the risk of disease and premature mortality. You expand your years of life. You enhance your quality of life, and we reduce healthcare costs. So on the surface of things, it's a fairly simple, important aspect of living is primary prevention. The problem is we don't really know how to help people to a certain extent. And you may not agree with all of what I talk about in these lectures, but just kind of keep an open mind and then go from there. So there's causes. We have to get into what are the causes of these behavioral lifestyle related issues, and then the causes of morbidity and mortality. But then what are the real causes? And we'll get into that in a little bit with the iceberg model. So here's what they tell you from the reading, basically the typical factors that influence these health behaviors. These are more kind of the traditional bigger picture types of things in terms of demographics. We know low socioeconomic status groups, for example, are usually eat more high-fat food, are less active, older versus younger. What's the value? Different cultures value different things. What are your goals? Social influence. Dr. Christakis at Harvard University has shown that your social network has a great influence on your behavior, and he's done work on obesity and smoking to show that friends of friends of friends influence you, and you may not even really know who they are. So again, if you want to know more, you could probably go find Dr. Christakis on a TED Talk that he gave. Very interesting. He calls social networks or social contagion. And this can happen both positively and negatively. So be careful, look around in terms of who are the friends of your friends of your friends, and that may give you a better idea of why you do certain things. Perceived symptoms, again, your access to healthcare delivery. That was kind of the whole big push by Obamacare, which we could have a long discussion about, but as well as cognitive factors, your knowledge and beliefs. So all of these things impact health behaviors in some way. You can find out more in the readings about them. The problem is, even if we know some of these factors, you have a list of 5 things here, these 5 bulleted items in terms of why it's so difficult to motivate sustained behavior change. Now, I'm not going to go over each one of these, but for example, just for the first one, different health behaviors are controlled by different factors. So for the same person, me or you, for example, different factors may determine my exercise behavior as compared to my eating behavior. And by different factors, I mean social, psychological, emotional, environmental, right? Getting into more of that holistic psychosocial perspective, right? So just think about, just for the same person, different health behaviors are influenced by different factors. And you could go down this list in terms of the complexity. So just kind of providing education and information to people and suspecting and expecting that they're going to change is probably a fairly simplistic perspective. So we have to kind of go a little bit deeper, and that gets us really into more of the iceberg model. And we'll come back to this at some point when we get near the end of the semester. But if you look on the left here with the holistic framework, and you look on the right, the disease management framework, and these 2 models of biopsychosocial and biomedical should pop into your brain right now in terms of which is aligned with which, right? Holistic would be what, right? More biopsychosocial. Disease management would be what? More biomedical, right? And so the biomedical model just usually typically looks at the tip of the iceberg in terms of factors like demographics, age, right? But the holistic model on the left says that you got to go below the surface. So this is where we get into health coaching, wellness coaching, where you need to establish more of an understanding of each individual. So is my life worth taking care of? What gives me fulfillment? What kind of life do I want to live? All of these factors are really causes of health behaviors. So you can't just focus on the tip of the iceberg. That's okay to start there perhaps, but you got to get below the surface in terms of looking at motivation for change, right? So yes, some people are motivated by reducing risk of disease or reducing the risk of disability, but that's not all of the people. So you got to get below the surface and getting into what are people's social connections, what is their purpose in life, what's happening at work. All of these things, all of these factors, the holistic factors influence whether or not people can do health behaviors over either starting and or maintaining. So the iceberg is a good metaphor to keep in mind as you get into your profession in terms of trying to understand, or scratching your head like, why won't these people do the things I ask them to do? It's probably a little more complex and complicated than you might think. So that's just something to keep in mind in terms of that iceberg model and why it's so difficult to motivate sustained behavior change. It's complicated. But getting back to this prevention umbrella, right, in terms of typically how we look at things, habits, adherence, compliance, prevention, risk, all of these words kind of come out of this biomedical model, right? We know the diseases that kill people. We know that behaviors and lifestyle relate to those diseases. Therefore, you need to develop the habits, you need to adhere to these behaviors, you need to comply to our prescriptions to prevent. And the way we do that typically in the profession is through attitude change and educational appeals. And many although we sometimes don't like to think that we do, but fear is used extensively. We try to create these persuasive messages that elicit too much fear, what can actually undermine health behavior change. So fear gets people to maybe think about it, but it's kind of short-lived. So information education is not enough. You have to kind of know how this information is being interpreted by the individuals, and is it really helping? And the data shows that fear is not really a good behavior change agent. Starting with what's wrong with people and scaring them about their future typically more or less paralyzes people, not necessarily motivates people. So again, just be careful about how you talk to your parents, your grandparents, your clients, your patients, in terms of understanding this kind of basic principle of behavior change. So because of some of the limitations of these past approaches with education and fear, and again, I'm not saying we don't need education, but that's kind of necessary but not sufficient enough. Theory came along, and I know some people roll their eyes when they hear about or listen to or have to read about psychological models or psychological theory, but theory did really kind of come into the picture in health psychology, certainly because of some of the limitations of more of the kind of just descriptive, surfacey kinds of approaches. And again, I'm not going to kind of get into all of the aspects of theory, but theory is really a set of interrelated propositions, including concepts that describe, explain, or predict a phenomenon. And so there's a lot of psychological theory out there. We're just going to kind of review a few of those. But theories are important because they really do identify the mechanisms of change, like why change occurs. And if you have a better understanding of why, your programs or your interventions can be more successful. Now there is a knock on theory because it's not based in reality, and there's probably some truth to that, but it's probably useful at least to get introduced to some of these psychological theories and how they relate to health behavior change. And I'm going to be stopping here shortly, but there's a lot of different kind of models or psychological theories, and again, you could go into the reading. I give you the page numbers and find out more about these. You can go from the health belief model all the way to more of social engineering approaches. Health belief model really looks at the perceived threat or perception that a particular health practice will reduce that threat. Self-efficacy is more of my confidence and ability to do the behavior, all the way down to social engineering, where you begin to modify the environment that positively can impact people's perceptions and motivation to change. Now the two models or theories that we'll review in the second lecture coming up is self-determination theory and the trans-theoretical model. These are probably two of the most popular. Number 3, which we won't review extensively, is the theory of planned behavior. And just a little aside, my doctoral dissertation at the University of Illinois way back when, I actually examined some certain tenets of the theory of planned behavior as it might be related to understanding of physical activity and behavior change. So again, and this was done with people at a work site in New Jersey, nonetheless. But anyway, so you get the idea that these theories are around. You can go into the literature and you can find all kinds of studies. But the two that we're really going to focus on are self-determination theory and the trans-theoretical model. And when I come back for the second lecture of Module 2, I'm going to help us explore a little bit more the basics of self-determination theory and the trans-theoretical model. I'm more familiar with the self-determination theory, but I will say the trans-theoretical model is probably used more by practitioners than any other model. It serves as the grounding for people who get certified in health coaching, for example, or wellness coaching. So we're not going to spend a lot of time on trans-theoretical model, but there is quite a bit in the reading, and I highly recommend that you understand both self-determination and trans-theoretical model when you're done with Module 2. So I'll be back with kind of a mini lectures on self-determination and trans-theoretical model.